Okay, let's dive in. Today we're tackling a really significant and honestly often heartbreaking topic: vertebral column trauma in animals.
Mm-hmm.
We're talking about injuries to the spine in our pets, covering everything from the bones, the discs, ligaments, right through to the absolutely critical spinal cord itself.
And these aren't subtle injuries, are they? We're talking about something sudden, usually from, a powerful external force.
Right.
And it can immediately lead to severe problems, anything from intense pain right up to complete paralysis.
And as you just touched on, the biggest concern, the thing that really changes everything with these injuries, is damage to the spinal cord. Spinal cord injury, SCI.
Yeah, that's the core issue. It has this potential for really devastating, sometimes irreversible consequences for the animal's ability to move, to function at all.
So our mission here today is to kind of unpack the source material we've looked at, pull out the most important insights.
Exactly. Think of it as getting the essential understanding quickly. What is this type of injury? What causes it? How do you spot the signs?
How do vets actually figure out what's going on? Diagnostic?
Right. Diagnostics, what the treatment options are, and maybe the toughest part, what are the real chances of recovery for these animals?
Okay, so let's start right at the beginning then. How do we actually define vertebral column trauma? What is it?
Well, simply put, it's an injury to the bones or the soft tissues of the spinal column, and it's caused by an acute, sudden outside force. It's that impact.
Got it. An external force hitting the spine.
Yeah.
So when that happens, what specific kinds of damage are we talking about?
You can see a few different things. There can be fractures, actual breaks in the vertebrae, the bones themselves.
Okay.
You can get luxations or subluxations. That means the vertebrae are dislocated, either completely or partially moved out of alignment.
Right, shifted.
Yeah. And you can see traumatic intervertebral disc herniation. So that's where one of the discs between the bones suddenly ruptures or bulges out.
Which then, that can press on the spinal cord, I imagine.
Exactly. And that leads us to the main event we really worry about: spinal cord injury itself. Whether it's a contusion, which is basically bruising,
Mm-hmm.
or compression from a bit of bone or disc material, or even, a laceration if something sharp penetrates, the damage to the actual nerve tissue is why these injuries are so serious.
Okay, so there's the immediate physical damage from the force. That's what you'd call the primary injury?
Right. That's the direct mechanical damage, the crushing or tearing happening right at the moment of impact. But, and this is where it gets really complex, there's also something called secondary injury.
Secondary injury. What does that involve?
This is a whole cascade of destructive biological events that kicks off after the initial hit.
Okay.
We're talking about things like reduced blood flow, ischemia, inflammation, swelling, edema, and the release of damaging chemicals, free radicals, excitotoxicity right within the spinal cord tissue.
Wow.
And these processes can actually spread the damage beyond the initial injury site. It can happen over hours, days, sometimes even weeks. It's like the injury just keeps getting worse from the inside out.
Like a delayed biochemical reaction that just adds more harm?
Precisely.
Yeah.
And a big part of the medical approach, actually, is trying to minimize this secondary injury cascade.
Okay, that makes sense. So how do pets typically end up with these kinds of really serious injuries?
Yeah.
What are the most common causes?
In dogs and cats, by far the most frequent cause is road traffic accidents, getting hit by a car.
Right.
That accounts for a huge proportion, especially you see it in dogs.
Yeah, sadly that makes sense. What else?
Falls from height are also a major cause, and you tend to see that more often in cats.
Ah.
Other things include bite wounds, from dog fights, gunshot wounds, unfortunately, crush injuries.
Mm-hmm.
And then less commonly, sometimes an animal might have something underlying, like a bone tumor or maybe an infection that weakens the spine.
So it doesn't take as much force.
Exactly. A relatively minor trauma can then cause what's called a pathological fracture.
Are there specific animals or situations where these injuries are just more likely to happen?
Well, based on the data we have, animals that spend a lot of time outdoors unsupervised, or those walked off-leash near roads, and definitely those not secured properly in vehicles, they seem to be at higher risk.
Stands to reason.
Yeah, they're just more exposed to the kind of traumatic forces involved. Looking at some studies, vertebral fractures and luxations showed up in about 6 to 7% of neurology cases presenting to specialized hospitals.
That's quite a few.
It is. Though the actual incidence of traumatic spinal cord injury without a fracture, that's harder to pin down. We don't really have solid numbers on that.
Any patterns in terms of age or breed?
Yeah, there seem to be some trends. The studies suggest affected animals are often quite young, median age around 2 years old.
Young dogs.
Yeah. And males appear to be diagnosed more often than females for some reason. Also, medium to large breed dogs are more commonly affected by the fracture and dislocation type injuries specifically.
Okay, so let's say an animal has unfortunately suffered one of these injuries.
Hmm.
What might you actually see? What are the signs an owner or a vet might recognize?
Well, the signs usually come on very suddenly, right after the trauma. And crucially, what you see depends entirely on where the injury is located along the spine and, of course, how severe the damage actually is.
So location and severity are key.
Absolutely. A thorough neurological exam is the absolute cornerstone. That's how you pinpoint the lesion location.
What are some of the general signs you'd look for?
Pain is almost always there, and often it's severe. It's usually localized right to the injured spot on the spine.
How would they show that pain?
They might yelp if touched there, be really reluctant to move, guard their back or neck. Sometimes they even shiver just from the intensity of the pain. That's sometimes called as hyperesthesia, an increased sensitivity. Then you see the neurological deficits. And that can be anything from, subtle weakness to complete
Like
paralysis.
difficulty walking or just not being able to move their legs
But
at all?
exactly. Paresis is the term for weakness. Maybe a hind limb looks weak, wobbly. Plegia means paralysis, complete loss of voluntary movement.
Right.
And depending on where the injury is, that could be paraplegia affecting just the hind limbs or tetraplegia affecting all four.
Forelimbs, okay.
Ataxia is also really common. That's incoordination, a kind of stumbling gait, seen in over 90% of these cases.
So they look unsteady.
Very unsteady. You might also notice they don't seem to know where their feet are properly. They might scuff their toes, trip easily, or stand with their paw knuckled over. That's a proprioceptive deficit loss of limb position sense.
Ah, okay.
And depending on the injury site, certain reflexes might be lost or conversely exaggerated.
Now this brings us to a really, really important sign that vets check for, doesn't it? The ability to feel deep pain.
Yes, absolutely critical, especially when an animal is paralyzed. Deep pain perception, or nociception, is checking for a conscious response to a strong, painful stimulus applied below the level of the spinal cord injury.
Like pinching a toe quite hard.
Exactly. A really firm pinch, usually with forceps on a toe or the bone. What the vet is looking for isn't just a reflex withdrawal of the leg that can happen even if the cord is severely damaged. They're looking for a conscious reaction.
What kind of reaction?
A yelp, turning the head towards the stimulus, trying to bite, maybe pupil dilation, some sign that the signal got all the way up to the brain and the animal registered it as pain. If they just pull the leg back without any of that conscious awareness, that's considered absent deep pain perception.
And the presence or absence of that conscious response.
Yeah.
That tells you something vital about the prognosis.
It tells you something hugely vital, yes. Its presence, even if they're completely paralyzed, suggests the spinal cord isn't completely functionally severed at that point. Some signals are still getting through.
That sounds hopeful.
It is, relatively speaking. Its absence, unfortunately, suggests a very severe, often functionally complete injury at that level. It's a major, major clue for prognosis, which we'll definitely circle back to.
Got it. What else might you see? Any other signs?
You can also see problems with bladder and bowel control, things like urinary incontinence, or maybe the opposite. They can't urinate voluntarily, so the bladder gets overly full urinary retention. Same with bowels, fecal incontinence, or constipation.
Right.
And in animals where the injury is more chronic, maybe recovery is incomplete, you might eventually see muscle wasting, atrophy in the affected limbs.
You mentioned earlier that the location really matters for the signs. Could you maybe quickly walk us through how the signs change depending on where the injury is?
Sure. So if the injury is high up in the neck, the cervical spine, say C1 to C5.
Right up near the head.
Yeah. It affects all four limbs. You'll typically see tetraparesis or tetraplegia, weakness or paralysis in all four. There's often severe neck pain. And the neurological signs in the limbs are usually upper motor neuron or UMN signs.
What does UMN mean in terms of how the limbs look?
It generally means the limbs might seem stiff or spastic, and the reflexes are often normal or even exaggerated, hyperactive. And if the injury is very high, like C1, C2, it can even affect breathing, cause hypoventilation.
Serious stuff.
Oh.
Okay. What about the next section down? Sort of lower neck, upper back. C6 to T2.
Right, the cervicothoracic junction. This also affects all four limbs and causes neck pain, but the pattern is different. You get lower motor neuron or LMN signs in the front limbs. LMN signs mean the limbs look weak, floppy, flaccid. The reflexes are reduced or absent. But in the hind limbs, you still see those UMN signs, stiffness, exaggerated reflexes.
Ah, mix.
Exactly. And injuries in this C6T2 region can also cause Horner's syndrome on one side of the face. That's a combination of signs like a constricted pupil, droopy eyelid, sunken eye, and the third eyelid might be raised.
Interesting. Okay, moving down the back now, the main body section, the thoracolumbar spine, T3 to L3.
Okay, so injuries here primarily affect just the hind limbs. You'll see paraparesis or paraplegia weakness or paralysis of the back legs.
Right.
And typically you see UMN signs in those hind limbs. Again, stiffness, maybe exaggerated reflexes. A classic test vets do here is checking the cutaneous trunci reflex.
The skin twitch.
Yeah, you gently pinch the skin along the back, and normally the skin muscle twitches all the way up. With a T3L3 lesion, that reflex will be absent behind the level of the injury. It helps pinpoint the location.
Okay. And finally, the very end of the spine, the lumbosacral area, L4 down to S3.
So this affects the hind limbs, the tail, and really importantly, bladder and anus function. You'll see hind limb weakness or paralysis, but here they'll show LMN signs floppy, weak limbs with reduced or absent reflexes.
So different from the T3L3 again.
Right, and you often see decreased anal tone, maybe a dilated anus. The bladder is often large, full, and very easy to express because the muscle tone is poor bladder atony. And the tail might be limp, hypotonic.
It sounds like these massive traumas often cause more than just spinal problems.
Oh, absolutely. Very frequently. Because the force involved is usually pretty significant, it's really common to find injuries in other body systems at the same time.
Like what?
Things like bruised lungs, pulmonary contusions, broken ribs, a fractured pelvis or other limb fractures, severe skin wounds, traumatic brain injury if they hit their head, or damage to internal organs in the abdomen like the liver or spleen.
So you have to look at the whole animal.
Critically important. Assessing the whole patient for all potential injuries is absolutely vital in the beginning. You have to prioritize life-threatening things first.
Okay, so you've got an animal, you suspect a spinal injury, maybe after a car accident or a fall. What's the diagnostic journey? How do vets figure out exactly what's wrong inside?
Well, the absolute first step before you even think about detailed diagnostics is stabilizing the patient.
Right, the ABCs.
Exactly. Addressing life-threatening issues, shock, hemorrhage, breathing problems, you have to handle them incredibly carefully, assuming the spine is unstable until proven otherwise. Often keeping them immobilized, maybe on a backboard, during the initial assessment.
And that neurological exam you mentioned earlier plays a big role here.
It's the cornerstone, absolutely. And it's not usually a one-off thing. Vets will repeat the neuro exam multiple times, especially early on,
Why repeat it?
to monitor for any changes. Are the signs getting better, worse, staying the same? It helps localize the lesion, assess the severity, including that really crucial deep pain perception test we talked about. Often, vets use standardized scoring systems, like the modified Frankel scale, to objectively track progress or deterioration.
Okay, neuro exam is key. What about actually seeing the injury? Can regular x-rays do the job?
X-rays or radiographs are usually the first imaging step. They're pretty good for spotting either fractures or major dislocations, maybe seeing if a disc space is narrowed, but they have limitations. Crucially, they can underestimate how severe the injury really is. They can miss up to about 25% of spinal fractures, especially subtle ones. And most importantly, they don't visualize the spinal cord itself at all.
So you can't see bruising or swelling on an x-ray?
Not at all. They're useful as an initial screen, and you definitely need views of the entire vertebral column just in case there's more than one injury site. But they often don't give you the full picture. Sensitivity is maybe 70% for fracture luxation, though specificity is high if you see it.
So you generally need more advanced tools to really get the details.
Exactly. For looking at the bones and assessing any instability, computed tomography or CT is really the gold standard.
CT for bones.
Yes. It gives incredibly detailed cross-sectional and even 3D images of the vertebrae. It's fantastic for seeing complex fractures, figuring out exactly which parts of the bone are involved, which is essential if you're planning surgical repair.
Makes sense.
CT is also really good for rapidly screening the rest of the body for those other traumatic injuries we mentioned, like lung bruising or abdominal bleeding. And it can sometimes show mineralized disc material or blood clots outside the cord.
Okay, so CT for bones and general trauma. What about seeing the spinal cord itself?
For that, magnetic resonance imaging, or MRI, is the gold standard.
MRI for the cord.
Precisely. MRI is far superior for visualizing the soft tissues, including the spinal cord parenchyma, the actual nerve tissue. It's what you need to see: cord contusion, bruising, hemorrhage, bleeding within the cord, edema, swelling, or a non-mineralized herniated disc pressing on the cord.
So it gives you the detail on the nerve damage.
Exactly. It provides really detailed soft tissue information, and it's essential for ruling out other conditions that might look similar clinically, like maybe a fibrocartilaginous embolism and FCE. And the findings on MRI can also give important prognostic information. It can see bone too, but CT is generally better for complex fractures.
So ideally, maybe both in some cases.
Sometimes, yes. If you suspect both significant bony injury and want detailed cord information, doing both CT and MRI can be really valuable to get the complete picture.
What about myelography? Is that still used much? I feel like I've heard of that.
Myelography is an older technique. It involves injecting a contrast dye into the fluid-filled space around the spinal cord and then taking X-rays or sometimes a CT.
What does this show?
It basically outlines the spinal cord, so if something is pressing on the cord from the outside, you'll see the dye column narrow or deviate at that spot. It can show compression, but it's invasive. It carries risks like seizures or worsening the neurological signs. And critically, unlike MRI, it doesn't give you any information about what's going on inside the spinal cord itself. You can't see bruising or swelling. So it's largely been replaced by MRI for evaluating the cord in most places. It might still be used if MRI isn't available, or sometimes in conjunction with CT for planning certain fracture repairs.
Okay. Any other diagnostics typically run?
Well, standard blood work, CBC, biochemistry, maybe blood gases important to assess the animal's overall health, check hydration status, look for signs of muscle damage, electrolyte problems, or systemic inflammation if there are other injuries.
And spinal fluid analysis, a
Yeah.
CSF tap.
Sometimes done, but it's often unremarkable or non-specific in acute trauma cases. You might see some increase in protein or cells, maybe some red blood cells if there was bleeding. But it doesn't usually pinpoint the cause and certainly doesn't replace advanced imaging. It's more of an adjunct test if done at all.
Okay, so we've covered what vertebral trauma is, the common causes, what signs to look for, and the whole diagnostic process. Now, the big one. What can actually be done to treat these animals?
Right. The main goals of treatment are, first, stabilize the patient overall. Second, decompress the spinal cord if something is pressing on it. Third, stabilize the vertebral column itself if it's unstable. Fourth, try to minimize that secondary injury cascade we talked about. And fifth, provide intensive supportive care.
I imagine pain management is a huge priority right from the start.
Absolutely vital, both for humane reasons these injuries are incredibly painful, and also because severe pain and the stress associated with it can actually contribute to and worsen that secondary injury process.
So good pain relief is actually therapeutic too.
Yes. Aggressive analgesia, usually starting with strong opioid medications like fentanyl, morphine, or methadone, is a high priority right away. And meticulous handling, keeping the spine rigidly supported during transport and initial exams, is also key. Managing shock with IV fluids if needed.
Okay. What if surgery isn't the immediate plan, or maybe it's not an option for some reason? What does medical or non-surgical management involve?
Medical management is often recommended for animals that have relatively mild neurological deficits, or if imaging shows the fracture or luxation is stable, or sometimes if surgery just isn't feasible due to cost or other health issues.
And what's the cornerstone of medical management?
The most critical component, bar none, is strict cage rest.
How strict are we talking here? Really strict?
Extremely strict. We're talking confined to a small crate or pen, basically 247, for anywhere from 4 to 8 weeks, sometimes even longer, depending on the injury.
Wow, that's a long time.
It is. They should only be allowed out for very short, slow, controlled leash walks, strictly for elimination purposes. No running, jumping, playing stairs. This is absolutely non-negotiable. It's essential to allow the bones and soft tissues time to heal without further movement causing more damage or instability.
Okay, strict rest. What about medications to help with inflammation? Now, I know you mentioned secondary injury, and I've heard a lot of discussion, maybe even controversy, around using steroids in these spinal injury cases.
Yes, this is a really important point, and it's an area where veterinary thinking has evolved quite a bit. Historically, high doses of corticosteroids, specifically methylprednisolone sodium succinate, or MPSS, were sometimes given within the first 8 hours of injury.
Why was that?
The idea came largely from some human spinal cord injury studies, suggesting it might help mitigate that secondary injury cascade, reduce inflammation, oxidative damage, that sort of thing.
But you said it's controversial now.
Extremely controversial in veterinary medicine, yes. The main issue is that while the potential benefits in dogs and cats with traumatic SCI are really not well proven, the evidence is mixed or lacking the potential risks are significant and well documented.
What kind of risks?
High-dose steroids can cause serious side effects. Things like severe gastrointestinal ulceration, which can be life-threatening, increased risk of infection because they suppress the immune system, pancreatitis, worsening hyperglycemia in diabetics.
Okay, serious downsides.
Right. So, given the lack of clear benefit and the very real potential for serious harm, many, if not most, veterinary neurologists and emergency critical care specialists today do not routinely recommend using high-dose MPSS for acute spinal trauma in dogs and cats. The potential harm is often felt to outweigh the uncertain benefit.
That's a really crucial takeaway for listeners. So routine high-dose steroids are generally out. What about other anti-inflammatories like NSAIDs?
NSAIDs like carprofen or meloxicam can be used for pain and inflammation in some cases. However, you have to be extremely careful. Firstly, you should absolutely never use NSAIDs and corticosteroids concurrently or even close together in time. The risk of severe, potentially fatal gastrointestinal ulceration skyrockets when you combine them.
Right, never combine them.
Never. And even used alone, NSAIDs carry a risk of GI upset or, less commonly, kidney or liver issues. So the vet needs to carefully weigh the potential benefits for pain control against the risks, especially considering the animal might be stressed, maybe not eating well, or might have received steroids previously.
So careful consideration needed. Are there other types of medications used in medical management?
Yes, sometimes muscle relaxants like methocarbamol or diazepam can be helpful if muscle spasms seem to be contributing significantly to the pain.
Okay.
And then there's managing bladder and bowel function, which is often necessary, especially in animals that aren't walking. This might involve manually expressing the bladder several times a day, or perhaps intermittent urinary catheterization to make sure it empties properly and prevent overstretching or infection. Laxatives or stool softeners might be needed for constipation.
Are there medications for bladder dysfunction too?
Yes, sometimes. If the bladder sphincter muscle is too tight, preventing urination, drugs like prazosin, an alpha receptor antagonist, might be used to help relax it. Conversely, if the bladder muscle itself isn't contracting well, detrusor atony, a drug like methanyl chloride, a muscarinic agonist, might be tried, but with caution as it can have side effects.
Complex management. What about physical rehabilitation? When does that come in?
Physical rehab is incredibly important for recovery, whether the animal had surgery or is managed medically. But, and this is key, it should only be started after the initial period of strict rest and healing, once the veterinary team is confident the spine is stable enough.
So not right away.
Definitely not right away if there's instability. Once it's safe, rehab helps regain strength, improve coordination, maintain joint mobility, and relearn how to walk. It can involve things like passive range of motion, massage, assisted standing and walking, hydrotherapy. It's crucial for maximizing functional outcome.
And for those animals that can't move at all, the recumbent patients.
Intensive nursing care is absolutely critical for them. This is a huge commitment. It includes turning them frequently, usually every 2 to 4 hours around the clock, to prevent pressure sores or decubital ulcers, which can be incredibly painful and hard to treat.
Every 2 hours. Wow.
Yes, keeping them meticulously clean and dry, providing thick, soft bedding, ensuring they stay hydrated, assisting with eating if necessary. It's intensive, demanding nursing care, often requiring huge dedication from the veterinary staff and especially the owners if the pet goes home.
That's a massive undertaking. Okay, so that's medical management. When does surgery become the recommended path?
Surgery is generally indicated when there's evidence of significant spinal instability, meaning the vertebral column itself is unstable due to fracture or dislocation and likely to shift further and cause more damage.
So unstable injuries need fixing.
Yes. Also, surgery is indicated if there's significant spinal cord compression visible on advanced imaging, like CT or MRI, particularly if the animal has severe neurological deficits, or if their signs are getting worse despite medical management, or if they have pain that can't be controlled medically.
So instability or compression or worsening signs.
Those are the main triggers. If the advanced imaging shows instability, like involvement of multiple parts of the vertebra, significant displacement, or something clearly pressing on the cord, bone fragment, disc material, blood clot, then surgery is usually the recommended approach for the best chance of a good outcome.
And what are the main goals of surgery in these cases?
There are usually two primary goals: decompression and stabilization.
Decompression first.
Decompression means surgically removing whatever is physically pressing on the spinal cord. This might involve removing bone fragments, herniated disc material, or blood clots. The most common surgical procedure to access the spinal canal and remove compressive material is called a laminectomy or hemilaminectomy, where a portion of the bony roof over the spinal cord is removed.
Okay, relieve the pressure. And stabilization.
Stabilization aims to mechanically fix the unstable parts of the vertebral column back together in the correct alignment. This provides rigidity while the bones and soft tissues heal. Surgeons use various implants to achieve this, things like special spinal staples, pins combined with bone cement, polymethylmethacrylate or PMMA, or more commonly now, sophisticated bone plates and screws, or rod and screw systems.
So internal fixation, basically.
Exactly, like fixing a broken leg but on the spine.
What about the timing of surgery? Does it need to be done immediately?
Generally, the recommendation is to perform surgery as soon as the patient is stable enough to safely undergo anesthesia. There's some evidence, particularly for compressive injuries, that earlier decompression might lead to better neurological outcomes. So it's often not delayed unnecessarily, but patient stability always comes first.
And post-operative care must be pretty intense, too.
Very intensive. It involves careful pain management, monitoring neurological status closely, managing the surgical incision, providing all that supportive nursing care if they're not yet mobile, and then gradually introducing physical rehabilitation once appropriate.
Okay, this brings us to the really critical question, the one I imagine every owner asks. What are the chances of recovery? What's the prognosis?
This is probably the most important and often the most difficult part of the conversation. The prognosis is highly, highly variable.
Depends on the injury, I guess.
It depends on several factors, but it really circles back to that critical piece of the neurological exam we discussed much earlier.
The deep pain perception test.
Exactly. The presence versus the absence of conscious deep pain perception or nociception, caudal to the lesion below the level of the injury, is overwhelmingly the single most important prognostic indicator for regaining the ability to walk ambulation.
Okay, so let's break that down. If an animal is paralyzed, maybe can't move his back legs at all, but it can still feel that deep pain pinch. What does that mean?
That animal, generally speaking, has a fair to good prognosis for eventually regaining functional ambulation with appropriate treatment, whether that's medical management or surgery.
Fair to good. That sounds relatively positive.
It is. It often requires weeks to months of intensive care and rehabilitation. It's a long and challenging road, but the likelihood of them eventually being able to walk again, maybe not perfectly, but functionally, is reasonably high. Client education should really emphasize this generally more favorable outlook if they choose to pursue therapy.
Okay, now the other side of the coin. What if they are paralyzed and have absent deep pain perception? They show no conscious response to that pinch.
This is where the prognosis changes dramatically. For functional recovery, meaning regaining voluntary walking and potentially urinary bowel control, the prognosis becomes guarded to poor.
Guarded to poor, that sounds bleak.
It often is, unfortunately. Many animals in this category, despite treatment, will remain permanently paralyzed and often permanently incontinent. They are at very high risk for lifelong complications like those painful pressure sores, chronic urinary tract infections, muscle contractures, and require exceptionally dedicated nursing care.
So the quality of life becomes a major concern.
A huge concern. And because of the poor prognosis for functional recovery and the immense lifelong care burden, euthanasia is, sadly, a very difficult but often necessary consideration discussed with owners in these specific cases.
Are there numbers on this? Like what percentage actually walk again if they lose deep pain?
For certain severe injuries, like a thoracolumbar fracture or luxation where deep pain is absent, the proportion of animals that regain functional ambulation is traditionally cited in the literature as being very low, often less than 5%.
Less than 5%. Wow.
Yeah. Data for animals with traumatic SCI without a fracture but lacking deep pain is a bit more limited, but the general principle holds. The loss of deep pain perception signifies a much more severe injury and carries a significantly poorer prognosis for walking compared to animals who retain it. It really is a critical dividing line.
Are there any other factors that influence the prognosis besides deep pain?
Yes, several other factors play a role, although none are usually considered as strongly predictive as deep pain status.
Such as?
Well, the progression of signs, if the neurological deficits worsened very rapidly after the injury, that generally suggests a more severe impact and a more guarded prognosis. The location also matters, as we discussed. Very high cervical injuries can be life-threatening due to respiratory compromise.
Okay.
The actual degree of spinal cord compression or visible damage seen on MRI can provide prognostic information. More severe visible damage often correlates with a poorer outcome. How stable or unstable the vertebral column is also factors in. Unstable injuries carry a worse prognosis if not surgically stabilized.
Does how quickly treatment starts matter?
Time to intervention can play a role, particularly for decompression in compressive injuries. Earlier diagnosis and appropriate treatment generally tend to improve outcomes, though the window isn't always clearly defined. The presence of those other serious concurrent injuries can definitely complicate management and potentially worsen the overall prognosis.
And the owner's role.
Hugely important. The owner's commitment and ability to provide the often intensive, long-term nursing care, rehabilitation, and management of potential complications like bladder issues is absolutely crucial for maximizing whatever potential outcome is possible. It's a partnership.
What are some of the long-term issues animals might face, even if they survive the initial injury?
Even with recovery, some animals might be left with chronic weakness, paresis, or incoordination, ataxia. Some, unfortunately, may never regain the ability to walk properly. Persistent urinary or fecal incontinence can be a lifelong management challenge. And again, for animals who remain non-ambulatory, those risks of skin ulcers and recurrent urinary tract infections are constant concerns.
It really underscores the severity, so prevention, where possible, seems incredibly important.
Absolutely. While accidents happen, simple measures can significantly reduce the risk of this type of external trauma. Keeping cats indoors, ensuring dogs are securely leashed or contained in fenced areas when outside, and properly restraining pets in vehicles are all highly effective ways to lower their risk of suffering these often devastating injuries.
Okay, let's try and bring this deep dive together then. What are the key takeaways?
Right. Well, vertebral column trauma is clearly a complex and serious condition. It involves injury to the bones and soft tissues of the spine, but the critical element is the potential for damage to the spinal cord itself, the SCI.
And the causes are usually those sudden external traumatic events, car accidents, falls being the big ones.
Exactly. Diagnosis hinges on a really careful neurological examination, especially assessing that deep pain perception, combined with advanced imaging. CT is the best tool for evaluating the bones and looking for instability.
While MRI is the gold standard for looking directly at the spinal cord tissue to see the extent of the damage, the bruising, the swelling, the compression.
Precisely. Treatment aims to stabilize the patient, decompress the cord if needed, and stabilize the spine if it's unstable. This might involve intensive medical management, where strict cage rest is paramount.
And remembering that the routine use of high-dose steroids is now very controversial and often not recommended due to the risks and lack of clear benefit.
Correct. Or treatment might involve surgery decompression and stabilization, particularly for unstable injuries or those with significant cord compression.
And when it comes to predicting the outcome, the single most critical factor, the major dividing line, is that deep pain perception test.
Absolutely. Its presence caudal to the injury offers a fair to good chance of walking again with treatment, while its absence signals a much more guarded to poor prognosis for functional recovery. It really guides treatment decisions and discussions about quality of life significantly.
It really is stark, isn't it?
Yeah,
Which
sure.
kind of leaves you with this final thought to ponder. Considering how much that one specific neurological finding, whether an animal consciously perceives that deep pain stimulus below the injury dictates the likely outcome, it makes you wonder about the exact biological threshold of damage within the spinal cord itself. What is it about reaching that specific point of functional disruption that seems to flip the switch from potential recovery, however difficult, to almost certain permanent loss of function?
Yeah.
It just highlights the incredible complexity and maybe the fragility of the nervous system. And it makes you think about what we still need to learn, what future research might uncover perhaps to bridge that gap somehow, to find ways to help even those animals who fall on the wrong side of that critical deep pain threshold. It really underscores how vital that connection is.